in this case it's hyperkalemia. When potassium levels exceed 5.5 milliequivalents per liter, you may get into the situation where you may actually get into the danger area of causing a hyperkalemic arrest. If you have potassium levels of 5 and you induce somebody from succinylcholine, the actual change in potassium normally is only around 0.4 milliequivalents per liter. So in other words, that person's potassium will rise to around 5.4 milliequivalents per liter, and it shouldn't have any significant deleterious effects. But if, on the other hand, if you have potassium up in the 6 range and you give the succinylcholine in that situation, now you're up to 6.4, and then you may get into problems. So you've got to make sure that the potassium levels are really not above, really around 5.5 before you put anybody under anesthesia. Okay? Because you never know when you may need succinylcholine, especially if you have a tough airway or a situation. So you got to get those problems repaired beforehand. Most of the time when you get potassium levels up that high, it usually indicates to you two major things. One is the kidney is not functioning, okay? Or you're having massive potassium being released from cells, which means it could be rhabdo, which is a very serious condition, and giving that person succinylcholine is also not a good idea. Okay? So it could be, it's very rarely due to increased intake. It could be from shifting potassium from intracellular fluid compartment to the extracellular. This is going to happen in patients that are severely acidotic. But the major issue usually is decreased renal excretion. It's one of the indications for doing dialysis, okay, is hyperkalemia. Manifestation is that the membrane hypopolarizes due to loss of the gradient, okay? And that means that the cell stays basically in a depolarized state. Okay? Initially, as the hypopolarized membrane becomes closer to the actual threshold, it actually increases irritability. Okay? So the person will get jittery and twitchy, but eventually, if you get too hypokalemic, you'll actually go into, hyperkalemic, you'll go into the depolarized state, and you won't get the cell to reactivate any further. Now we see this in OB quite a bit. How many people worked in OB? Nobody? Okay. You know, I used to people, I had more people from OB. But anyways, one of the things that you see is when you have somebody with a severe hypertension from pregnancy, is that we'll treat the basically situation with high doses of potassium, okay, or magnesium, sorry, and we'll get into that in a minute. But the hyperkalemia is usually seen from two simple sources in the clinical situation: is a gross overdose, okay, or from a situation where you get like in cardioplegic solutions, okay. One of the things that we've had in the past is that we've had several deaths in the operating room from patients being given potassium chloride IV directly. So all anesthesia cards have been removed of all potassium in it. Okay? You cannot find potassium in the ORs anymore. So if you're a nurse used to working in the ICU and having potassium readily available, it's something that we don't really allow you guys to have in the operating room. Okay? It's not safe. Okay? They've had several reported deaths of people giving potassium because they thought it was a muscle relaxant, because it looks like the same vial. So it was getting drawn and injected directly, and the patients were getting hyperkalemic arrest, to say the least. It's not something you can get back from most of the time. These hyperkalemic arrests are much more severe than those induced by succinylcholine and are very, very difficult to reverse. Okay? It can be done, but you've got to have prolonged CPR, and the chances of that person not waking up with significant brain damage is pretty high. Things that will, if you get very high levels of potassium to take place, eventually the cells is not able to repolarize. It results in muscle weakness, loss of muscle tone, flaccid paralysis, and eventually the muscle and the pacemaker ability goes into asystole. Magnesium is the next electrolyte, in this case the next cation. It's actually the second most common intracellular cation. Okay? It acts as a cofactor in many proteins and nucleic acid synthesis reactions. And it's also very critical for the production of ATPase activity. It decreases acetylcholine release at the neuromuscular junction as well, which is something that normally you don't have to worry about because most magnesium is pretty heavily regulated. Hypomagnesemia can occur for many different reasons. It can occur from dietary malnutrition. It can also be from malabsorption problems such as small bowel dissections. Patients that are alcoholic are also very commonly hypomagnesemic, and unfortunately that's a high percentage of our population that we deal with is from high doses of alcohol. So unfortunately that induces so many other disease processes that you end up dealing with hypomagnesemia quite often. You can also get it from renal tubular dysfunction. Some forms of severe metabolic acidosis will also drive the magnesium out of the blood completely, and you'll get significant hypomagnesemia develop. And then you can also excrete it at too high a quality by the kidney by giving them loop or thiazide diuretics. Okay? The problem with magnesemia, hypomagnesemia, is associated with hypocalcemia and hypokalemia as well. So it's usually something that you have to always think of when you see somebody with having hypokalemia. Okay? Make sure you check your magnesium levels, and actually it's become pretty much a standard in my repertoire of taking care of patients. Anytime I order a potassium level, I immediately check a magnesium level and an ionized calcium level. It's just one of those things that you'll see that's significantly depleted a lot of times in the operating room. Okay? More so than you think. Okay? Where you see the hypocalcemia very frequently is somebody that's hemorrhaging and that you're giving more than 4 units of packed RBCs. The citrate that's inside the packed RBCs is what's preventing it from clotting. It acts as basically as a calcium sump. Basically, it pulls all the calcium out of the plasma or in the blood. So it acts as a depleter of calcium and leads to a significant hypocalcemia. Now, the problem with hypomagnesemia is it causes neuromuscular irritability. It can cause tetany and convulsions, and it can cause hyperreactive reflexes. Magnesium is actually something that we use to treat preeclamptic patients so they don't go into eclampsia. And when we give too much of it, will eventually lead to loss of deep tendon reflexes. Okay? So initially, if you're low on magnesium and you start treating this person with magnesium, that rapidly gets better. And one of the things that they'll use in OB is they'll do they'll check the twitch, not the twitch, but the reflex by doing prepatellar. My brains are fired today. I don't know what it is. Anyways, they take the prepatellar region and they hit it with a hammer. Okay, and the OB nurses check this very frequently to make sure that you're not losing the reflex. If you're losing the reflex, then you basically induce a hypermagnesemic state, and you can actually stop the person from breathing if you continue doing that high level of dosing. Okay. Hypermagnesemia causes significant skeletal muscle depression. Now, because of this, you have to really I'll tell you a little story clinically, okay? When you work in OB, one of the things that will happen is you'll be immediately called to take this person back for immediate C-section. And everybody immediately takes everything off the pumps and immediately rushes the patient back to the operating room, okay? And one of the things that I have a pet peeve about is that you'll see me say this over and over again, is that if that person is preeclamptic, make sure when they take the magnesium off the pump that you disconnect the tubing completely from the patient. Okay, you cannot have magnesium free running in your IV. Okay? Because if you have it clamped, you think, well, that's fine, it's not going to be a problem. Well, sure enough, you go to the OR and somebody decides to help you. And says, you know, the IV is not running fast enough, because they look at the IV and they say, they don't look at the bag, they just look at the IV drip and it's got nothing running through it. So they're going to help you, and they're going to open up the magnesium for you. Okay? Now you're going to give 3 grams of magnesium, and now the person's going to be looking at you like, I can't move, and they won't be able to breathe, and then they'll say, oh, it's from the spinal. You got a high spinal. No, you just gave a hypermagnesemic overdose. Okay? So, and you think that's not a joke. I've seen people die from that. So it's something you don't want to do. Okay? You can get severe hypotension with it as well. You can get respiratory depression, of course, because it causes not only skeletal muscle weakness, but it also causes diaphragmatic weakness. The person will appear lethargic and drowsy, and eventually will cause a severe bradycardia to develop. Calcium is the third most important. Most calcium is found in your body as bone, and it's complex via what's called hydroxyapatite. That's usually something that's, it's a reservoir for calcium. Okay? But really what matters to the cells is the free ionized calcium portion. Okay? In the old test, they used to do what's called a combined calcium, which not only gives you the ionized fraction, but it's also the protein-bound calcium. And what we used to do is we used to do an equation based on the albumin to figure out what the ionized calcium was. I can tell you from all the studies it's completely bogus. Okay? The only way you can actually tell how much ionized calcium is in the bloodstream is by actually doing an ionized calcium test. So if you go back and work in a small little hospital that doesn't do ionized calcium, you need to talk to the pathologist and say, look, we need ionized calcium for the OR because nothing else is equivalent. Okay? And the guy says, well, it's fine, and you can calculate it out. And I said, when's the last time you read about this? Okay? And they usually go back and read about it and says, yeah, I'll order it for you. Okay? Because all the literature says it's useless. Okay? So you really need to get the ionized calcium to tell you what's occurring in the bloodstream. If you don't know what the ionized calcium fraction can be, you can lose contractility of the heart. You can begin to lose the ability of the person to contract properly their skeletal muscles, so they'll get significant weakness in their muscles. Okay? So calcium is one of those essential compounds that are really needed for many, many processes. Besides being a structural component of bones and teeth, it's also critical in the blood clotting cascade phenomena. If you don't have enough ionized calcium, the blood will not clot. Okay? It's also important for neurotransmitter release as well as neurotransmitter release. Okay? So it's also important for hormone production because those are essentially vacuoles that are being released into the bloodstream. Anything that needs to exit a nerve ending, okay, has to do it through what's called a calcium binding phenomena. Okay? And I'll show you that later on when we talk about nerve cells. Okay? So hypocalcemia will lead to depletion in neurotransmitter release. It's extremely essential for cell receptor function. It's essential for contraction of muscles. It's also very important for plasma membrane stability because it helps stabilize the membrane and decreases fluidity. It also alters the plasma membrane permeability. And most of the intracellular calcium that we see is actually found in high concentrations in the mitochondria. Okay? If you're looking at specialized cells like the cardiac muscle, you have T-tubules as well as sarcoplasmic reticulum. They're responsible for this in the skeletal muscle. It actually holds a lot of the calcium. Calcium and phosphate are basically friends that are always hooked at the hip. If the calcium level is increasing, phosphate levels must be falling. Okay, phosphate levels are rising, calcium levels must be falling. So they're always going in reverse directions of each other. Okay? You never want an increase in calcium and increase in phosphate together because then you'll form what's called calcium phosphate crystals, which means you'll crystallize in your bloodstream, and that's very bad. Okay? Not a good thing. Things that regulate these essential electrolytes are parathyroid hormone, which actually increases your calcium levels. The other thing that's important is vitamin D, which is a fat-soluble steroid, as well as calcitonin, which decreases your plasma calcium levels. Hypercalcemia leads to a decreased production of parathyroid hormone, which then leads to a decrease in renal activation of vitamin D. This basically then tells the intestinal tract, which is your major source of calcium under most circumstances from dietary intake, to drop its absorption. Okay? The actual kidney also decreases reabsorption of calcium, which means that it allows calcium to be wasted into the urine. And it also leads to a decreased excretion of phosphate. So in other words, as calcium begins to fall, it begins to cause phosphate to increase. There's, of course, a decrease in calcium resorption from the bone. In other words, the calcium is left in the bone under hypercalcemic states. On the other hand, when your patient's becoming hypocalcemic, let's say their ionized calciums begin to fall, then the parathyroid gland becomes activated to try to increase the actual levels of calcium in your bloodstream. So the increase in parathyroid hormone leads to an increase in activation of vitamin D. And the actual vitamin D is critical for this whole cascade. If you don't have vitamin D, I don't care how much parathyroid you throw at it, it's not going to make a difference. Okay? Where's your vitamin D from your major source that you're getting it from? Your sun. Okay? Except if you look at most milk cartons now, they're fortified with vitamin D. Okay? And that's how we've gotten rid of most of our problems nutritionally, is by fortifying or adding things to normal things that you eat. Okay? So vitamin D deficiency leads to a disease process in children called what? Rickets. Okay, rickets. Okay? Now, when you do get an increase in the activated form of vitamin D, it leads to an increased absorption of calcium, okay, which increases your renal reabsorption of calcium as well as an increased excretion of phosphate. You begin to waste phosphate, and you get an increased resorption of calcium, which may actually lead, in some disease states, to loss of bone density. Okay, so elevated parathyroid hormone levels can actually cause the bone density to deplete very rapidly. Okay, so it's one of the things you also have to worry about. Hypocalcemia causes our inadequate intestinal absorption, lack of active forms of vitamin D, decreased levels of parathyroid hormone, so that's a part of the cascade, increases calcitonin levels. If you transfuse with citrate, it also induces hypocalcemia, which is the most common cause intraoperatively. And also, you can see hypocalcemia and malabsorption of fat. It leads to a decrease in the block of sodium into the cell, and manifestations that you get is an increase in neuromuscular excitability, prolonged QT interval, and actually a decrease in contractility, as well as a decrease in systemic vascular tone. So these people can become hypotensive very, very severely. Yes? Malabsorption of the bowel. Okay, you mean intestinal absorption, you mean? Okay, what was it? ADEC is a fat soluble. They're fat soluble. ADEC is the vitamins, okay, which is a fat soluble vitamins. So if you have malabsorption of fat, you get a malabsorption of vitamin D. Okay. Hypercalcemia is an increase the block of sodium into the cell. So it's one of the things that you have to worry about with hypercalcemia. It basically begins to inhibit the ability for the depolarization to take place properly. So that's going to make your muscles weak as well. And so both of these, hypo or hypercalcemia, are both going to make you weak. Okay? One may be simply the mechanism of not having enough calcium getting into the cell to cause the muscle contraction. And the other one, by being on the higher side, inhibits the rapid sodium channels from working properly because they begin to compete with it. Okay? The calcium that's coming in will compete with the sodium trying to come in. And as a consequence, you don't depolarize the cell fast like you're supposed to. And as a consequence, you don't get the muscle contraction like you should. So cells can become refractory to depolarization. Causes of hypercalcemia can be significant, such as hyperparathyroidism. Bone metastasis can also induce this issue, and excessive vitamin D doses can also cause this, although that's exceedingly rare. Manifestations include decreased neuromuscular excitability. The person basically will appear weak. Kidney stones will develop as well because you will start developing calcemic urine crystals, and you'll get also severe forms of constipation with this as well. The next electrolyte is phosphate. Phosphate is essential for life. If you don't have enough phosphate, you cannot form ATP. It's one of the essential compounds of conversion of AMP to ADP to ATP. So it acts like also as an intracellular as well as an extracellular anion buffer. The most important extracellular buffer remains as what? Bicarb. Bicarb is the most important extracellular buffer. Intracellular phosphate is a very important anion buffer. Okay? Serum extracellularly can be bound the phosphate via what's called phospholipids, phosphate esters, and inorganic phosphates. Intracellular, by far, is the most important part of it. It's a high-energy bond that's located in the creatinine phosphate, which forms ATP. So without phosphate, you can't get ATP production, and you just rapidly die. Okay? How many people here are gardeners? A few of you. Okay. I garden all the time. So one of the things that you have to give your plants for them to be happy is you give them phosphate. Okay? And what you're doing is you're basically providing them enough nutritional supply so they can have ATP production. Okay? Calcium and phosphate concentrations are rigidly controlled. Okay? If the concentration of one increases, then the other has to decrease. Otherwise, you're going to get the crystallization that takes place. I've seen people that actually have had very high levels of calcium and elevated levels of phosphate. And we actually put an A line in this individual. And when we actually put the arterial line, we had a very hard time penetrating to the actual radial artery. Eventually, we did get it in. And the post-op day number 3, when they pulled out the A line, they had a heck of a time stopping the hemorrhaging. Okay? The actual artery became so calcified and so stiff that the artery wouldn't stop bleeding. And they actually had to put a patch over it to eventually stop it from hemorrhaging. So it can be pretty nasty. As you can imagine, the arteries in that kind of situation become like steel, and these people have huge problems with, and they sit up and lay down because their arterioles can't vasoconstrict and cause arterial tone. Hypophosphatemia is caused, on the other hand, by intestinal malabsorption problems. Okay? We actually induce a certain degree of hypophosphatemia because in renal failure patients, by giving them what? K-phos. Okay? The stuff binds to phosphate, okay, right before people eat. Okay? Not K-phos, what's it called? Foslo. Okay, that's what I'm thinking of. Okay? Foslo is basically given to everybody who has renal failure because it binds to the phosphorus. So you can't get an accumulation of this, and you can induce a hypophosphatemia. But because the kidneys fail so badly at that point, usually you're fighting hyperphosphatemia at that point. Okay, so it can be from intestinal malabsorption. It can also be from a renal excretion of excessive amounts of phosphate. Situations like hyperparathyroidism will also induce this, as well as respiratory alkalosis. The manifestations is that the bones will become very softened by this, which develop what's called osteomalacia. And the other thing that hypophosphatemia, besides lack of ATP production, it also leads to a decrease in production of 2,3-DPG. 2,3-DPG is very important for oxygen delivery. It's very important for it to extract the oxygen from the hemoglobin and assist the hemoglobin from shifting over to a format that allows the oxygen to come off the cell, so off the hemoglobin molecule. So 2,3-DPG in this kind of situation can be significant enough that the person cannot deliver enough oxygen to the tissue, and you can get some degree of metabolic acidosis that can occur. You can also lead to leukocyte alterations, which means the white cells, which require a lot of ATP to work properly, do not, and then the person has an increased risk of infections as a consequence. Hyperphosphatemia results in hypocalcemia. Okay, remember we said it always goes in reverse, so you get hypocalcemia, then it usually leads to hyperphosphatemia. Okay? Usually the hypocalcemia is what leads to the majority of the symptoms. If you give too much phosphorus, it's also dangerous because it actually causes cell death. High phosphate levels are related to low calcium levels, which of course are the ones that cause most of the symptoms. Okay, now we're going to talk into acid-base concepts. Okay? We're going to keep it pretty simple. We could sit here and talk about different forms of acid-base formulas, but I'm going to just keep it very simple. Just keep it as hydrogen ions is what we're going to talk about most of the time. Okay? Acids are anything that increases the hydrogen ion concentration. Okay? Remember the pH is equal to the negative log, the inverse log of hydrogen ion concentrations. Okay? So if the hydrogen ion concentration goes up, the pH falls. As for a base, it basically can accept the hydrogen ion. Okay? Proteins are considered bases. Okay? And hemoglobin is also a very important hydrogen ion acceptor in your bloodstream. Okay? Your blood is extremely important for buffering, or basically inhibiting the action of hydrogen ion concentration shifts. Okay? If you had to say which one has the lowest concentration in your bloodstream of all forms of electrolytes, what would be the lowest, do you think? Hydrogen. Hydrogen is extremely low in concentration. It's kept that way all the time. A small change can make a huge change in pH, and as a consequence, it's very heavily regulated. Okay? pH is the inverse log of the hydrogen ion concentrations. If the hydrogen is high in number, then the pH is low or acidic. If the hydrogen is low in number, then the pH is in the adverse reverse, which is high or alkaline. The normal pH range is between 0 to 14, and in human beings, for survival, we usually live at 7.40. And we live in a very, very tight range. Okay? If we're up in the 7.6 range, we're not doing very well, and we're down to 7.2 range, we're really not doing well either. Okay? So 7.4 is really where we want to live. Anything above that, by 0.2, the person's critically ill. Okay? The lowest I've ever seen somebody's pH is 6.9, and they didn't do very well. Okay? The lowest survival one I've ever seen is about 6.95. So some of you, of course, have had somebody that's lower that survived, but that's fairly rare. Okay? On the other hand, being alkalotic is very dangerous too. Okay? Being up in the range of 7.7, 7.6 is very dangerous because you no longer allow oxygen to come off the hemoglobin pretty much. Okay? You need, if you have a choice between being acidic and alkalotic, I'd rather be acidic. Okay? Because that means that oxygen is going to come off your hemoglobin versus if you're alkalotic, the oxygen is not going to come off the hemoglobin, and then you get into all sorts of trouble from that. Okay? So the pH is very, very highly regulated by your body. Okay? Now the way the pH is regulated is by a system called buffers. Okay? By far the most important buffer in your bloodstream is bicarb. Okay? And bicarb indirectly is controlled by CO2. Okay? We'll get into that in a minute. For every change of 1, you see a factor change of 10. So that shows you how much the pH can really significantly change the hydrogen ion concentration. But still, the actual hydrogen ion concentration in your bloodstream is actually one of the lowest numbers around. Okay? Acids are a natural byproduct of most metabolism. Okay? It forms from protein metabolism, carbohydrate metabolism, or fat metabolism. So all of your essential fuel products, you're going to produce acid. Okay? And that's an important concept because one of the byproducts is not only acid, but it's also CO2 and water. And CO2 itself will actually convert into H2CO3, which is carbonic acid, which forms and releases hydrogen ion. So you have to have some system in there that has to equilibrate this acid and maintain this, this balance to take place so you don't get as severely acidotic from metabolism. The normal range is what expected for tests is 7.40. Okay, that's where you should always think of normal pH for human beings. Okay? The major organs involved in regulation of acid-base balance are, believe it or not, lung. Lung in the sense it has to regulate CO2, kidneys, and bones. Bones by far are just the long-term player. Lungs is usually the immediate player, and the kidneys is the intermediate player. The body acids exist in basically two forms. It exists as volatile acids or non-volatile acids. The lung can get rid of all volatile acids. Okay? It means it can breathe it out. Okay? Volatile means that it's forming a gas that can come out. What we're talking about when we're talking about most volatile acids, we're talking about CO2, okay? Carbon dioxide. Okay? When you form carbon dioxide plus water, you have to know this equation, it forms into carbonic acid. Okay? Carbonic acid then separates rapidly into hydrogen ions and bicarb. Okay? Now, if I increase my CO2 production, what do I eventually lead to? An increase in hydrogen ions. So as a natural byproduct of increased metabolism is that I increase my production of hydrogen ion, and as a consequence, the person's pH begins to fall. Okay? Anytime you begin to run in heavy exercise, your pH is actually becoming acidotic. Okay, if you begin to exceed your minute ventilation to get that gas out, then the actual pH will fall really rapidly, and the person will develop severe cramping pain from that. Okay? As for your non-volatile acids, these are things like sulfur, okay? Sulfuric acids, phosphoric, and other organic acids, and they have to be eliminated by the kidney. Okay? So you have no way of eliminating non-volatile acids by the lung. Okay? Now, what prevents the changes in hydrogen ion concentration? So these are very highly regulated. Remember, I just said before, hydrogen ion concentrations are very low. If you have to pick a choice in a test, and it says, which one is higher concentration? Potassium, chloride, sodium, and hydrogen ions. It's going to be hydrogen ions every time. Okay, so one is heavily regulated and maintained at a very steady state. So how is regulated? Well, it's regulated by buffers. Okay, these are chemical acid buffers in the body fluids. Okay, the most important buffer system is the bicarb system, and it's in your blood. There's also a phosphorus buffer system, which we'll talk about later. These are rapid in the sense that they are able to neutralize the changes in pH very, very quickly. The classic example of this is, let's say you drink a bunch of lemonade that's very acidic. Okay? When it gets into your bloodstream from the digestive tract, it doesn't make you severely acidic right away. It doesn't, because the buffers immediately stop that from happening. Okay? If it's a volatile acid, the lung is the next mechanism that tries to regulate the acid-base status by allowing the CO2 to be removed. And if you begin to increase your volatile acid production, which means you increase your amount of CO2 production, the brainstem will activate the respiratory drive to increase minute ventilation. So most people will breathe faster and increase their minute ventilation and blow off the CO2. If you're under anesthesia and you can't do that, then your CO2 will begin to build up, and the person will become increasingly more acidotic during the case. And the last mechanism, which takes several hours to days, minimum of 6 hours, maximum of 24 to 48 hours, is the kidneys. Okay? They're able to excrete not only the volatile, which in other words it forms either hydrogen ion, it releases that through the kidneys, which is what makes most urine is acidic, and it reabsorbs bicarb in the process of releasing this hydrogen ion in the kidneys via countercurrent mechanism. The other thing the kidney is able to do is to also remove the non-volatile acids as well. It's slow though. The buffer system is a chemical that can bind excessive hydrogen ions or hydroxy ions without significant change in pH. A buffer is any substance that can be reversibly bind hydrogen ions, okay? And the buffering pair consists of a weak acid and its conjugate base. The most important plasma buffering system is a carbonic acid bicarbonate system, okay, which we're going to talk about more in respiratory physiology. What happens in the system is that CO2 that's being produced in the tissue is partially dissolved as CO2, which is a very small fraction. Most of the CO2 is immediately converted into carbonic acid and forms hydrogen ions and a bicarb. Okay? Some of the CO2 gets dissolved through and enters into the red blood cell, where you have a very rapid enzyme inside there, which is essential, which is called carbonic anhydrase. Okay? Carbonic anhydrase is what converts CO2 and water into carbonic acid. Okay? What's interesting about the red blood cell is that it takes that hydrogen ion molecule, okay, and binds it to the hemoglobin, okay, which helps basically carry the CO2 back to the lungs, okay, and also helps unload the oxygen at the tissue plane level. The bicarb, on the other hand, is then immediately released into the plasma fluid space, which then acts like a buffer for other hydrogen ions. Okay? In the process of doing this, it does it via what's called the chloride shift. For every bicarb that you pull out, you have to pull in one chloride ion. Okay? And that kind of makes sense for electrical neutrality. Okay? Eventually, this comes back to the lung, and then this whole step reverses, and the lung is able to let the CO2 come out of the system into the alveoli. Okay? Now, how much CO2 is in your body? 120 liters. That's a lot. Okay? How much oxygen is in you? 1.2 liters. Okay? And the way you remember that is always think about it this way. The normal oxygen consumption rate that you need to survive is around 250 cc's per minute. Okay? And that's actually what our anesthesia machine is always set as a default value for the flow that's going through the flow meter. So 250 cc's if you forget to turn it on. Okay? So that's sort of another reminder. Okay? So if you were to breath hold for 5 minutes, you would basically extinguish all your oxygen that you have in your bloodstream. Okay, so 5 times 250 is equal to 1250. So it's 1,250 milliliters of oxygen. So it's 1.2 liters of oxygen. That's all you have in your bloodstream. So there's not much of it. But on the other hand, there's 120 liters of CO2. Okay? And it's not that it's in CO2-free form. 90% or 80% of it is in bicarb form. Okay? So that acts like a huge buffer. Okay? It has a tremendous capacity to accept the extra hydrogen ions. Okay? You see here how much the concentration. Look, bicarb accounts for 70% that was actually dissolved in your blood. 23% is actually carboxyhemoglobin. Okay, I'm not carboxyhemoglobin, but what's it called now? I can't remember. Carbaminohemoglobin, which is 23%, and then you have 7% that's actually dissolved. Okay, so CO2 really is a very small percentage dissolved in your bloodstream. When you see the CO2 coming back in your blood gases, in other words, when you draw it from blood gas out here, what's your normal CO2 out here in your artery? It's 40. When you draw your blood gases, what's the number that comes back? 40, right? Okay? So that equals to a pH around 7.40, and if everything else is normal. Okay? When it comes back, what's the blood gas value on your venous CO2? What is it? 80, 90, 100, 44, 50. It's only 44. It's not that much. Okay? So it didn't increase that much. Okay? But by the time it comes out of your blood in the alveoli, it's back down to 40. Okay? So everywhere in your system, when it comes into your arteries, it's still at 40. Okay? So there's a certain amount that CO2 is always in the arterial side. Okay? You can't get rid of it, all of it. Because as soon as you get rid of it, what happens? Yeah, exactly. The other bicarb that's sitting there will convert it into CO2. Okay? Now, when we give an IV drug, let's say I give a venous drug, okay, which we call sodium bicarb. Okay? What happens when I look at my end-tidal CO2? Okay, so what I'm doing is I'm infusing a very high amount of bicarb here in the bloodstream in the venous side. What do you think is going to happen before it hits the lungs? It's going to rapidly shift in this direction, forming CO2. So what you see on your end-tidal CO2 is all of a sudden a spike in end-tidal CO2 value of CO2 production. And if you give it too fast, you'll actually impair cardiac motility. So one of the things that we tell you, if we're giving bicarb to somebody who is not under a cardiac arrest condition, okay, we say to you, push the bicarb slowly to see only a little bit in rise in CO2, let's say 2 to 4, without causing an impairment of the heart. If you start seeing that the CO2 changes from, say, 35 and all of a sudden you're at 55, you're giving it too fast. Okay, and the person's blood pressure will all of a sudden fall. You'll see like the person have a little bit of arrhythmias, and they won't like it very much because you're inducing a too rapid change in the pH. Okay. Does that make sense? Did I lose anybody? Okay. Anyways, the most important buffer in the extracellular space is the carbonic acid bicarbonate group, okay, which I just told you, the carbonic anhydrase is the most important one of these enzymes that converts conversion of CO2 to water into carbonic acid. Okay? This enzyme is not present normally in your blood vessels and except inside the red blood cells. Okay, so in the red blood cells, carbonic acid is in very high concentrations. The other where you find this also in very high concentrations is in cells of the lung alveoli, as well as in the renal tubules. Okay? The carbonic acid operates in both lung and the kidney at a pH of 7.4. The ratio of bicarbonate to carbonic acid is 20 to 1. Okay? So without this enzyme, you wouldn't have this taking place. If the amount of bicarb decreases, the pH as a consequence will decrease, for making the person more acidotic. This type of pH adjustment is referred to as compensation. The respiratory system normally compensates by increasing or decreasing ventilation depending on how your pH values, how much your CO2 values are doing at the time. Now, the most important intracellular buffer, make sure you note the difference. Extracellular was carbonic acid, okay, the CO2 system, okay. The most important intracellular buffer is actually phosphate, okay. And that makes sense because CO2 is going to be rapidly depleted out of the cell. You don't want CO2 to stick around, right? It's a metabolic waste product, so you want it to get rid of it, okay. So on the other hand, a normal buffer that is very important for a lot of energy production is going to be something that you want to keep inside the cell. So it makes sense that phosphate would act as a buffer as well, besides being a major important source of energy. Phosphate is a very important molecule because it's able to accept hydrogen ions very easily. So as a consequence, keeps the person's acidity very well controlled. When we start later on talking about pKa, and especially when we talk about local anesthetics, let's come back to this discussion. Basically, pKa is if you were to have that pH at that pKa, 50% of the reaction forward would be the same as the 50% of the reaction behind in the front. Okay, so it tells you, let's say you're giving the reaction that we're talking about is water plus CO2 forms carbonic acid. And let's say we're giving that the pKa is like 6.7. If I had a pH of 6.7, 50% of the molecule will be CO2 and water, and 50% would be carbonic acid. Okay? That's what the pKa is trying to tell you. It's equivalency. Now that pKa, of course, will vary depending on what compound you're talking about and what pH you're talking about as well. Now the other buffering systems that are intracellularly important are the protein buffers. Proteins do have negative charge, so they serve as hydrogen ion acceptors, so they do act as buffers. Okay? The other one that's also important in the bloodstream is hemoglobin, which is an excellent intracellular buffer. Okay? It accepts hydrogen ions onto, via the Haldane effect, onto the hemoglobin molecule. And again, this will be going over this in a lot more detail in the respiratory section, so I'm not going to get you to memorize that just yet. The other important buffering system is the kidney. Okay, the kidney is able to secrete hydrogen ions as well as produce bicarb. It also is able to produce diphosphate, dibasic phosphate. Renal buffering is important for the intracellular buffer system because it helps form the phosphorus. Okay? The other thing that the kidney is also able to do is to be able to waste hydrogen ions via ammonia, and also things that it can get rid of is lipid soluble agents at times, not too much so. Most of the kidney reabsorbs the lipid soluble agents. Respiratory regulation of acid balance by far is the second line of defense for acid-base balance after buffers. CO2 is a normal volatile acid that's made intracellularly as an end product of metabolism. Remember that CO2 can be expired because it's a volatile acid, and it forms in high enough concentrations in your bloodstream, it immediately converts into carbonic acid, and then it converts into hydrogen ions and bicarb. Okay? The bicarb is still maintained at high concentrations, and usually that can offset most of the hydrogen ion changes that are occurring and taking place. So ultimately, CO2 has to be removed, otherwise, if you don't, hydrogen ions begin to accumulate and they develop a respiratory acidosis very rapidly ensues. Okay? Increase your alveolar ventilation. It leads to a decrease in extracellular hydrogen ion, and as a consequence, you develop alkalosis. Okay? This equation shows you what happens when a person is hyperventilating. CO2 levels will fall. In other words, the reaction is shifted in that direction, eventually leading to hydrogen ion concentrations falling. On the other hand, if you decrease alveolar ventilation, you will get the reverse effect. Okay? If you do get an increase in hydrogen ion concentration, let's say some forms of some forms of acidosis that are developed, the hydrogen ions will combine to bicarb and increase CO2 production, and usually that will stimulate more alveolar ventilation to take place. If you impair the lung function, then the CO2 begins to accumulate and you get the reversal of this reaction, and as a consequence you get into respiratory acidosis. Renal control of acid-base balance, okay, the renal tubule function, the hydrogen ions are secreted by secondary active transports in the early tubular network. Okay? So hydrogen is very rapidly put into the tubular system, which is your urine. So the urine is mostly acidic most of the time. It will, the bicarb that is filtered was rapidly reabsorbed. Okay? And pretty much the kidney tries everything it can to reabsorb bicarb and not waste it. There is some primary active secretion of hydrogen via intercalated cells in the late distal, which is over here, and the convoluted and the collecting tubules. So it also helps waste more hydrogen ions. So the urine is always, most of the time, it's acidic. Okay? You can make urine alkalotic if you drink enough alkaline material, but most of the people have significant urine that's acidic. Generating new bicarb can be done by the kidney as well, but this is slow. It does it by basically wasting hydrogen ions in the distal convoluted tubule, which we'll talk about that later when we talk about kidneys. The phosphate buffer system also generates new bicarb, as well as ammonia helps generate bicarb as well. And we'll again talk about all this in the kidney section. Don't be memorizing this too much, it's just too early right now. This is what we're going to get into the kidney. Please do not memorize this. What I'm trying to show you here that it is something we are going to get to, and we're going to discuss this in more detail once we get to the kidney section. But just understand that the kidney has a tremendous ability to reabsorb reabsorb bicarb at the same time waste hydrogen ions into the urine. Okay? And we'll get into all the details of that later on. Now, what occurs in acid-base imbalance is what we're going to talk about in the last hour, so we'll stop here for 10 minutes.